This presentation is going to be about suicide risk assessment and the ISPath WARM. So let me just talk about a couple different things. First off, there's a difference between suicide risk assessment and suicide prediction. Suicide prediction says we already know and we can predict who will commit suicide. That's not the truth. Actually, what we as counselors can do is a suicide assessment. Say it aloud. Ready? Suicide assessment. Good job. Suicide assessment. Suicide assessment means that we're not 100% certain what the outcome is going to be. But based on the risk factors that are present, we're going to make some hypotheses, and we can't predict with 100% accuracy what will happen. But what we will do is make an assessment to see what risk factors the client has. And that's basically what we're going to be doing with a suicide assessment. And hold your hands out for a second, okay? On the left-hand side, take your left hand. Good job. Take your left hand. And that's going to mean where your left hand is extremely suicidal at this moment in time. Take your right hand, put your right hand on out. That means lacking significant suicide risk factors. So our client's going to land somewhere between immediate extreme risk and lacking significant risk factors. So they're going to land somewhere along this continuum. We just don't know what the end result will be. So we're looking at between, at this moment in time, being extremely suicidal, in other words, having a lot of risk factors, that's your left hand right now, to lacking significant risk factors at this moment in time. So basically what we can do is do an assessment which is imprecise at best, and it tells us about what's happening immediately with the client. Let me give you an example of this. In about 1990, I had a client who I was seeing for depression, nicest guy you can possibly imagine. His wife was angry at him because he wasn't making enough money. He had just gone out and purchased a tow truck. This is up in Michigan. In the wintertime, cars break down in Michigan and run off the roads a lot in Michigan. So he just bought a tow truck, and he had been towing all day long and made lots of money. When he came to my office for our session, he pulled out a wad of money and he said, "Dr. Junkie, look at all the money I made. My wife will love me now." Well, she never did love him, but at this moment in time, he was thrilled because he had made all this money, and his wife had been bitching and complaining that he hadn't made money. So he was getting ready to head home to show her how much money she had made so she'd stay with him and love him forever, and they'd have a wedding and marriage in paradise. Anyway, he took one last call, pulled the truck out of the ditch, and then he drove home. And in Michigan, in the wintertime, it gets dark really early, like 5:30 p.m. It is pitch black outside. So he parked his tow truck out front, walked into his home, unlocked the door, walked into his home, and he said his home felt cold to him. And he also said he flipped the light switch and the lights wouldn't go on. And so he flipped another light switch and that light wouldn't go on. So he walked back out to his tow truck, grabbed his flashlight, and looked through the house. And, as he's standing in the doorway and looking in the house, he's flipping the light switches and nothing goes on. And so he looked over at a lamp that he was trying to switch on and off, and the light bulb was gone. He walked to the front closet, and all the clothes from that front closet were gone. He's shining his light around and walked through the kitchen, and nothing was there. No food, nothing was in the pantry. And he was like, "What's going on?" He walked into the bathroom, and in lipstick on the mirror, it said, "F you, I'm leaving." And that's when he decided to kill himself. He didn't have those thoughts about killing himself when he was with me, because in the immediate, he had a wad of money. He felt good about life. He thought his wife would stay with him. But in that moment, when he got to his house and she had taken out all the light bulbs, there were no hangers in the closets, there were no clothes, no food in the pantry, he plummeted and he was suicidal and made a suicide attempt, otherwise known as a parasuicide. We don't say suicide attempt. I shouldn't have said that, because that implies that a person is such a loser that they didn't even know how to kill themselves. So we call it a parasuicide. And basically that is the idea that they attempted a suicide but did not be successful. They were not successful. So one of the ways we look at doing our assessment is through an instrument called ISPathWarm. Say it for me. Ready? ISPathWarm. ISPathWarm. Now, ISPathWarm is an acronym, and it goes through a number of different words. There are 10 words in ISPathWarm, and they're basically looking at the greatest predictors of suicide. The instrument was created by the Association for Suicidology, and they were looking at the 10 greatest risk factors. Now, a caution here. If in your gut of guts you believe somebody's suicidal, you need to do something. If you're going to err, make sure you err on the side of caution. So that means hospitalizing somebody if you really believe that they're suicidal, or if you have a gut feeling that they're suicidal. Part of being a counselor is doing no harm to others. And one big problem would be is if we said somebody isn't suicidal and they go off and kill themselves. So the ISPathWarm is looking for 10 risk factors. Hold 10 fingers up, 10 risk factors, okay? Created by the American Association of Suicidology, and it is an acronym. ISPathWarm is an acronym, and it's looking for 10 different risk factors. So the first risk factor is suicide ideation. Ideation is the I for is. I is for ideation, suicidal ideation. Does the client have suicide ideation? Do they have suicidal ideation? Are they thinking about killing themselves? Now, I'm going to make some distinction here that AAS did not. First off, there's a big difference between suicidal ideation and suicide intent. Let me say that again. There's a big difference between suicidal ideation and suicide intent. Let me give you an example. If somebody says, I'm thinking about killing myself, that's suicidal ideation. They're telling you about thoughts of killing themselves. If they say, I'm leaving, going home, and going to take my Glock 9, put it to the side of my head and blow my friggin' brain out, that's intent. So if you ask somebody, are you thinking about killing yourself? And they say, oh, I have some thoughts about, hurting myself, thoughts about killing myself. That's suicidal ideation. This is what AAS was looking for, suicidal ideation. But Jerry Junkie is looking for, even more than suicidal ideation, suicide intent. One way I check that out, at the end of my clinical assessment for suicide, I ask people, so what are you going to do after you leave here today? And if they say to me, when I leave here today, I'm going to go blow my friggin' brains out, or I'm going to go lay on a railroad track, or I'm going to drive the wrong way up the interstate. That's suicide intent. That is a double alarm in my brain. Now, for ISPathWarm, all they have to have is ideation. I'm thinking about killing myself. But what Jerry Junkie is looking for is intent. Do they say that when they leave there today, when they leave our session today, their intent is to go kill themselves? Or are they saying, my intent is to go out with my girlfriend. We're going to go have dinner at, I don't know, what's a place here in San Antonio? I'm thinking of a place, Chuy's. We're going to go have quesadillas at Chuy's and triple margaritas. So there's a difference between intent and ideation. I also want to talk about intent in a different way than what the scale talks about intent. Say FID, F-I-D, FID. FID stands for frequency, intensity, and duration. Let me give you an example. Frequency, how many times a day, how many times an hour, how many times a minute are you thinking about killing yourself? So if they have high frequency of thoughts of killing themselves, they're a danger to themselves. High frequency. So if they have a high frequency of thinking about killing themselves, there's a higher probability they will kill themselves. The I stands for intensity. Say, intensity! Got it. Think about this. Suicide! So if they have high frequency and high intensity of killing themselves, they are at significant risk. And you got to do something about that. They're saying, oh, thinking about killing myself. Once a week or so, screw them. That's not high intensity. High intensity is suicide. I'm going to kill myself right now. Okay? So if they have high frequency, constantly thinking about it, high intensity each time they're thinking about it, and high duration. So their thoughts of suicide aren't just fleeting suicide, but they're suicide. They have high frequency, high intensity, and high duration. The probability of them killing themselves is quite high. Okay, we can't guarantee it, but in our assessment, frequency, intensity, and duration are very important to look at. Now, the ISPath-WARM doesn't look at intent to kill cells. It's just about ideation, and it doesn't break down frequency, intent, and duration. But you, as a counselor, need to be an expert. And part of being an expert is you need to look and differentiate, is it suicidal ideation or is it suicide intent? If it's suicide intent, you got to do something. If frequency, intensity, and duration are high, you got to do something. However, on the ISPath-WARM, they're just looking for suicidal ideation. But for junkie, it's frequency, intensity, and duration of suicidal ideation. And if they're talking about intent versus ideation, that's a triple red flag. So let me try to summarize just the I so far in ISPath-WARM. So ISPath-WARM, one thing that I do is I go through the 10 risk factors in ISPath-WARM, but then I look at and I ask them, what are you planning on doing when you leave here today? And if they tell me, oh, I'm planning on going home, putting a shotgun in my mouth and pulling the trigger, I write that in my notes, and that to me is enough to hospitalize somebody involuntarily. You getting what I'm saying? If their intent right now is when they leave my office to go kill themselves, I have to do something. If, on the other hand, they're telling me how suicidal, all their suicide thoughts, blah, 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 and they don't have frequency, intensity, and duration, I'm not as worried. But just because they said that they had ideation, I've got to record that. And I ask, so what are you going to do when you leave here today? Oh, I'm going to go home. I'm knitting something. I'm knitting a scarf for my boyfriend, and I'm just starting that out. And I'm going to put that in my notes. Client indicated when she leaves session today, she's going to go knit a scarf for her boyfriend. How long does it take you to knit a scarf? Oh, 3 to 4 days. Client says it takes 3 or 4. So she's not saying right now, there's an imminent danger, I'm going to go kill myself. She's saying, I'm going to take 3 or 4 days and make this, knit a scarf for my boyfriend. So for junkie, that's not high risk. But for the ISPath-WARM, just the I for ideation, that's one risk factor. And what we're trying to do is we're trying to get a score of all the immediate risk factors this person has. So for ISPath-WARM, that's just one risk factor. But for junkie, say junkie. Come on, you can say junkie. I'm looking for frequency, intensity, duration, and I'm looking at a difference between suicidal ideation. I'm thinking every once in a while, fleeting thoughts every Thursday when I go out drinking, I'm thinking about killing myself. Or is it intent? When I leave this friggin' place today, I'm going to go kill myself. Now, for involuntary hospitalization, and let me just clarify. From 1986 until today, I do a lot of risk assessments for suicidal ideation. So I used to work crisis intervention in Ottawa County, Barrie County. I used to do crisis intervention for Minor Adams counseling as a consultant. I used to be in private practice. When I did that, people wanted me to do risk assessments. In Ottawa County, I drove all around the friggin' county. I think we had 2 jails, 3 hospitals, multiple foster care homes. So anytime somebody was at risk of harm to self, they would call me to do an assessment. I worked for Ottawa County. When I worked for Barrie County, it was the same thing. So I'm on call 24/7. I'm on call all weekends and evenings. My job was, when somebody was talking about suicide, My job was to say either they're going to the hospital or they're not going to the hospital. What I want to do is teach you from that vantage point. The second risk assessment in ISPath-WARM is substance abuse. Are they abusing substances? Well, if you're in my 5613 substance use disorder, my addictions class, every one of our clients are going to be using substances. Now, let me talk a little bit about Jerry Junkie's perception of this. For AAS, Association for Suicidology, what they were looking for is if somebody has suicidal ideation, they'd get 1 point. If they have substance abuse, they get 1 point. But Jerry Junkie has been doing this for 40 some years, right? So when I hear about them using substance abuse, now filter this on out, I'm thinking about what substances are they using? So if they tell me that their substance of choice is cocaine, what do we know about cocaine? Cocaine fires us up, gets us all excited, and we go do things impulsively while we're on cocaine. We just do them. It's like being in a manic phase. So if your client's in a manic phase or using cocaine, that gets my attention, because if they have one thought about suicide, if they even have a little bit about suicidal ideation and they're using cocaine, the probability of them acting on that thought is intensified. If they're using cannabis, marijuana, let's use some marijuana together. Ready? Here's our blunt. We got it. We're set. Oh, wow. What are we doing with cannabis? We're chilling out. If they're using cannabis, cannabis still could be, for the ISPath-WARM, cannabis is a substance. So using that would be their second factor. But for Jerry Junkie, if they're using cannabis and they're just chilling out is probably not going to result in suicide. It means that they're, Now, it doesn't mean that they can't. It means that, they may be doing things that they typically wouldn't do, or maybe they're just relaxing and then they're ready to kill themselves. And I'm going to investigate that during my assessment by asking questions about that. But if they tell me they're on cocaine, I'm thinking about killing myself. Oh God, I'm going to go home. Kill myself would be good. I like that idea. Let's go do it right now. Okay, that is cocaine taking on over. If they're telling me that you're getting drunk Thursday night through Saturday or Sunday, they're blacking out, that means alcohol is a depressant. More alcohol when you're depressed makes you more depressed. You don't have the same boundaries that you do when you're not intoxicated. So for my substance use class, think about this. Most of our clients are going to score the S on substance abuse. So for most of our clients in the substance abuse class, there'll be suicidal ideation. I'm thinking about it. For most of our clients, there's definitely going to be substance abuse. So they would receive 2 points, okay? The P in PATH is ISPath-WARM. The P in PATH, P stands for purposelessness. Purposelessness. No reason for living. Let me ask you a question. Why do you live? What's your purpose in life? Do you live for yourself, your spouse, your boyfriend, your girlfriend, your significant other, your children? What's your purpose in life? If you don't have a purpose in life, if you have no purpose to live, the probability of suicide increases. The A stands for anxiety or agitation. Let me ask you a question. Don't answer the question aloud, even though I'm on videotape, I won't hear you. But let me have you ask a question. Have you ever had anxiety? Well, first off, there is no diagnosis in the DSM-5-TR that's a good diagnosis. No one ever goes, yay, I've got major depression. Ooh, that's terrific. At least I'm not psychotic. Well, you might be down the line, so don't jump to that conclusion. But anxiety and panic disorders are wicked stuff. They are mean. People who are anxious want to die. They would like to die to escape. So think about it. Anytime somebody has anxiety, agitation, unable to sleep, and an immediate problem, they're concentrating. Have you ever been anxious? I have. When I'm anxious, I'm constantly thinking over what could happen. All right? So instead of going to sleep, I'm thinking, oh, tomorrow this could happen, then this would happen, I'm constantly thinking about it. So anybody who has anxiety, the A in path is path warm. Anybody who has the A is at higher probability of killing themselves. The T in path means trapped. I feel trapped. There's no way to escape this life's pain. For example, people who have a severe medical problem, a severe disease or illness, and they're ultimately going to die, and especially if it's going to be painful. So the old diagnosis of Lou Gehrig's disease or Alzheimer's, the idea that this is going to be a long death and I'm not going to be able to control my situation, and especially if it's going to be that I'm going to be a drain on my family. Who do you love? Do you love your significant other, your partner, your wife, your children, your grandchildren, your professor? Who do you love? Who do you love? People you love, you don't want to make their lives miserable. And oftentimes what happens is when people feel trapped, they're feeling that they can't escape and that they're in a situation that they can't get away from. Now, I used to have this with the U.S. military when I was a consultant for 82nd Airborne down in Fort Bragg or Pope Air Force Base or soldier and family branch here in San Antonio. People who feel trapped. I can't get out of this. I feel trapped. I can't escape from the Army. I can't go AWOL. I've got to be here. I've got a deployment coming up. I'd rather be home with my wife and kids, but I can't be. I'm trapped in this friggin' Army. And they're going to deploy me to Afghanistan or wherever it's going to be. Feels like they're trapped. If they have a feeling of being trapped, they get another point. The H in path stands for hopelessness. Does this person have a negative sense of self or others or their future? In other words, do they have a negative sense about who they are or about their future? Take somebody in substance abuse, I'm just saying. Somebody in substance abuse might have a child, an adolescent, an adult child might have gone through recovery. Their parents might have paid for recovery services, paid for them to go inpatient recovery, and they relapse. And then they feel like, shucks, I went ahead and I just, because recovery programs, inpatient recovery programs, are about $30,000, $40,000 a year for a really good program. And parents will remortgage their house for their kids, not once, not twice, but typically like 3 different times. So the kids, even the adult parents, are feeling like, jeez, I let my parents down. So they probably have very negative feelings about themselves and about their future. I'm always going to be an alcoholic. I'm always going to be a drug abuser. So when they have these feelings of hopelessness, that's when they become more suicidal. Does the future appear hopeless? Is there little positive chance for them? So let's just repeat these first, what are these? The first few risk factors. The I stands for ideation. If they have ideation, they have 1 risk factor. If they have substance abuse, they have a second risk factor. If they feel purposelessness, they have a 3rd risk factor. If they have anxiety, they've got a 4th risk factor. If they feel trapped, they've got a 5th risk factor. If they feel helpless or hopeless, actually it's not helpless, it's hopeless. They feel hopeless, they've got a 6th. So a client who has 6 risk factors, they're going to say, no danger of killing themselves. Baloney. If they have 6 risk factors, there's a high probability they're going to kill themselves. The W in warm stands for withdraw. Are they beginning to withdraw from people, friends, family members? Many times my clients who are suicidal would withdraw from work friends, family members, especially parents, loved ones. They just withdraw because they feel like they're impinging on other people. They're making other people sad. So they will withdraw. The A in warm stands for anger. Anger. When was the last time you really had anger? Possibly in the parking lot when somebody stole your parking place. I was talking to somebody recently and they said that they were angry with somebody who stole their parking lot underneath the bridge at UTSA. And I said, so what did you do? I was thinking, were they going to run into their car or, get out of their car and scream at them? And the person said, no, it wasn't, no big deal. All I did was go find another parking place. That's not true anger. True anger is when you take your car and they steal your parking place and you ram into their car with your car, or you jump out of your car and you scream at them. You take your gun that you've got and you shoot through the windshield. There's your anger. It's uncontrolled anger. It's seeking revenge. And let me talk to you about suicide for a moment, because there was a case that I'm aware of where a supervisor at work kept turning down a male. She was a female. She kept turning down a male who was inviting her out for lunch and a movie and dinner. He had a crush on her. She kept turning him down. And then she felt bad. He was an okay guy. She didn't have any romantic feelings towards him, but she felt bad. I'm always turning him down. So he asked her out again. He said, okay, one movie, one dinner, one movie. They went out to a movie, and after the movie, he tried to kiss her, and she was like, I don't want to be kissed. Stop it. I don't want that. I don't want that. This relationship's not that kind of a relationship. I'm not going to be going out with you anymore. And he said, what are you talking about? You're not going to go out with me. You used me. You had me pay for your dinner, and you had me buy a movie ticket for you, and you owe me. And she was basically like, what? Stop it. I have no romantic feelings for you. I told you it'd be a one-time thing. She lived in a 3-story apartment building. She went and got ready for bed that night. She crawled into bed. At about 3 o'clock in the morning, she heard all this rumbling and everything out on her balcony of her 3rd-story apartment. She had vertical blinds. Those are the ones that go up and down. And so she was like, what the heck's going on? Do I have a cat out on my balcony, or what's going on? And so she opened the blinds. And when she opened the blinds, she saw in the light from the street light this guy take gasoline from a red tank, gasoline tank, and pour it over his head and then ignite himself. Many times people who are suicidal have a desire to seek revenge on other people. So in the is path warm, anger is a risk factor. If they have rage, uncontrollable anger, they're seeking revenge, that is anger. So they get another point. The R in warm stands for recklessness. Recklessness. Say recklessness. Good job, recklessness. That's acting or engaging in risky activities, seemingly without thinking. Let me ask you a question. When was the last time you went down 281, you drove down 281 during rush hour traffic and closed your eyes? Hopefully the answer is never, right? When was the last time you were on I-10 and you were smoking cannabis and drinking alcohol? Hopefully never, all right? But those are reckless activities. So what you're doing is you're asking people about reckless behaviors. Have you ever drank to the point of intoxication and driven your car? Have you ever drank and drove? Is it drank and drove? Drank and drive. Drunk and drive. Have you ever done that? Have you ever used cannabis and then got in your car and, went for a drive down I-10? You're looking for, reckless behaviors. So if somebody has reckless behavior, that's another risk factor. The M in warm stands for mood changes. When people have dramatic mood changes, it typically means that they're moving from one mood to another mood very rapidly. And if they do that, they have these rapid mood changes, the probability is that they're at higher risk, because all they have to do is think about suicide, and there's a high probability that they might act on those risks. So let's just jump back. Is path warm? You've got 10 risk factors. Hold up 10 fingers. Good job. What's the first risk factor? Good job. Ideation. Suicidal ideation. What's the second risk factor? Substance abuse. Good job. Third risk factor, purposelessness. When I don't feel there's a purpose in my life. Number 4, anxiety. When I have anxious feelings. The number 5 is trapped. When I feel like I'm trapped in a hopeless situation. When I feel like I'm trapped in a situation that I don't like. For example, have you ever had your wisdom teeth pulled out? The night before you have your wisdom teeth pulled out. Don't know about you, but I was pretty darn anxious. I was like, night before surgery, I'm thinking, oh God, I don't want to go through that. That's feeling trapped. I'm going I'm going to get this happen. I'm going to tell you this story. One time I had a situation where they had to do some surgery on my foot, unexpected surgery on my foot. I was like, okay, I'm in a doctor's office, everything's cool. Once they put me in a gurney and they put me down rolling me down the hall, I'm like, oh shucks, I want to get out of this situation. I don't want them to cut into my foot or into my, I don't want that. I was scared of this. I'm scared of this. And they said, oh, relax, you'll be fine. We do this lots of times. I'm like, I don't want this at all. I was crawling out of that gurney, and it wasn't until they gave me a shot that kind of knocked me out. Think about, for those of you who've had, the colonoscopies, the night before, you're drinking all this stuff, and it's like, oh golly, I can't handle this. This is horrible. It's the panic beforehand. All right. So it's the idea that I'm feeling trapped here. And then the H in PASS stands for hopelessness. Does the client have feelings of hopelessness? If they do, they're at higher risk of suicide. The W in WARM is withdrawal. Are they withdrawing from friends and family members? The A in WARM is anger. Do they have rage or uncontrollable anger? Are they thinking about suicide? Are they saying they want to get even with a spouse who left them, or a boyfriend or girlfriend or friend who broke up with them, somebody who divorced them? Many times people who have gone through a really horrible divorce, they want to get back at the other person. They want to get back at them so much that they'll go ahead and kill themselves in a miserable way and leave a note, you made me kill myself. Instead of being happy and doing what they want to do, what do you like to do? I mean, this is Jerry asking you right now, what do you like to do? I like to paint. I like to lift weights. I like to do karate. I like to sing. I like to do a lot of different things. So instead of doing any of those fun things for me, what I'm going to do is I'm going to go kill myself to make the other person feel bad about what they've done for me. This is totally illogical. It doesn't matter. It's the situation. So uncontrollable anger, seeking revenge, rage, anything like that would fulfill the A for WARM. Recklessness, acting in a reckless or risky behavior. And then mood swings, dramatic mood swings. All those are risk factors. So what we're looking for in the ISPath WARM is we're looking for a cluster of risk factors. The greater number of risk factors, the higher probability of them killing themselves. Is it that they will kill themselves? No. It means right now, at this moment in time, based on what they said, we believe this person has a high probability. Listen to the word. I don't say they are going to kill themselves. I say they have a high probability for suicide based on their current risk factors that they talk about. Or they have a low probability of suicide immediately. They have a low probability of immediate suicide based on their lack of suicide risk factors acknowledged. So like the tow truck driver, they might not be thinking about suicide at all when you're in your office, and you might do this risk assessment and say, they have a low probability of immediate risk factors. They have a low probability of suicide, but when they get in their car, things could change right away. So, or they have a high probability because they have a lot of immediate suicide risk factors. Therefore, they have a high probability for killing themselves. Doesn't mean that they will. It means that they have a high probability for that. I had a client one time, and we were in session, and I was doing couple or marriage therapy, and he said, I'm going to friggin' kill myself. And usually I can call people on back, and I said, hey, before you come back, let's talk about this a little bit. He was like, no, I'm going home. I'm going to take the Glock 9mm handgun in my lampstand next to my bed, and I'm going to shoot myself. That's suicide intent right there. Long story short, I met with him a couple months later, and I said, what happened? Last time we were talking, you were on your way to kill yourself. He said, I was totally intent on killing myself. I got in my car, I drove down to the corner, and it was in the wintertime in Michigan. He said, I drove up to the corner. He said, I'm crying and carrying on. And a beautiful woman showed up in the car next to me and she said, "What's wrong?" And he says, "I want to kill myself." Now, this is back when we had roll-up windows and roll-down windows in Michigan. So she basically pointed at a restaurant bar and she said, "Okay, pull in there." And they pulled in there and she said, "What's going on?" He said, "My wife just left me." And she said, "Let's go inside and have a couple drinks." They did a line of cocaine, they had drinks, and they decided that he had married the wrong person, that he should have married this woman he just met at the stoplight. So even though people might be in immediate risk, a lot of things can go on to change. The ISPATH worm will never 100%, it's not designed to be 100% accurate. It's looking at immediate risk factors. So we make our assessment based on those immediate risk factors. And when we write up our report, we're looking, do they have a high number of immediate risk factors? And when we write our report, we say the client reports few suicide risk factors, and therefore we don't see him as an imminent risk. Or the client has an abundance of risk factors, suicide risk factors, and we perceive him to be an immediate, imminent risk. That's what we're talking about. Now, just want to clarify something here. I used to use the SAD person scale: sex, age, depression, previous attempt, ethanol abuse, rational thinking, loss, social supports lacking. The O stands for, I can't remember what the O, and the S stands for sickness. It was an ongoing suicide plan. So you'd look at that, you'd count up the risk factors, and from there you'd create, it would tell you hospitalize, strongly consider hospitalization, don't hospitalize. It would have all these different things based on your risk factor scores. The ISPATH worm is like, hey, we don't say hospitalize or not hospitalize. All we're talking about is the number of risk factors. And so when you write up your report, you don't say, based on the ISPATH worm score, we believe this person is in imminent danger to self. And the ISPATH worm says the person's in imminent danger and should be hospitalized. What we do is we say the person had 8 out of 10 immediate suicide risk factors. When asked, the client said she was going to go home and kill herself. Or when asked, she was going to go home and knit a blanket. So always ask at the end of your suicide assessment to see, always ask, where are you planning on going? What are you planning on doing when you leave my office? For suicide, involuntary hospitalization, typically it's imminent danger to self, immediate danger to self. We can't predict what's going to happen a month down the road, let alone 3 hours down the road. But based on the here and now, and they're saying they have high frequency, they have intent, not ideation, but intent, high frequency of intending to kill themselves, high intensity of thinking of killing themselves, high duration of those thoughts. And they're telling you a suicide plan. They've made a recent suicide attempt in the last month or two. All those things indicate higher probability of killing themselves. So write that into your report based on the client's indication that he tried to kill himself 2 nights ago. I'm concerned for this client's safety and believe that, and today when asked, he said he was going to leave my office and go kill himself. He had an attempt 2 weeks ago or a week ago. He right now says he's going to go kill himself. That means you've got to do something. He's indicating intent, not ideation. That means you've got to do something. And you might say, well, he can't sue me because he's going to kill himself. He's dead. You know what? It's never the client who sues you after they die from suicide. It's their family members and loved ones, because they don't want to admit, I missed all these indicators that Jury Junkie was suicidal. They're not going to say, oh my God, he was saying all these things and I didn't believe him. No, they're not going to say that. They're going to say, we brought him to you to do an assessment for suicide and you screwed up. It's your fault, Mr. Counselor, Ms. Counselor. It's your fault, not us. We knew there was something wrong. We even brought him to you because we thought he was suicidal. Listen to me, folks. This is really something. If you believe that person is a danger to self, you have to do the involuntary hospitalization. Now, here in Bexar County, we're very lucky because we have a special group with the Bexar County Sheriff's Department that will do the suicide assessment for you. But you're a counselor. You need to know what are the risk factors. So here in Bexar County, now around the country, they can dial 988 if you've got somebody who's suicidal, 988. But here in Bexar County, you can dial 911 and say, I believe I have somebody in my presence who is suicidal. I want a Bexar County Sheriff's suicide assessment team to come do a suicide assessment of him or her or them. And they will do that. Where I was up in Michigan, Michigan had weird laws. So if I thought somebody was suicidal, and I would say, I want you to go, involuntarily into the hospital, they go like, screw you, I'm not gonna go in the hospital. And they would walk away from me and say, hey, come back here. I can't do a thing. There's nothing I can do. So I'd have to get a hold of the district attorney's office. And typically that meant driving to the district attorney's office, waiting to speak to the district attorney, and then telling the district attorney my assessment and what I thought would happen. And then the district attorney would typically say, Jared, that sounds like you're right. This person's saying that they're going to kill themselves. They got a shotgun. They're going to blow their brains out. They're going to do this. I think that another assessment is warranted. So then they'd put out an all points bulletin in the police department. I didn't have the client. They don't know where the client's at. They'd put out an APB on the client. They'd go hopefully find the client within the next 24 hours. Then they'd bring the client to an emergency room where a physician would go ahead and do a suicide assessment. This is all screwed up. If they were going to kill themselves, they probably would have killed themselves already. Okay, so I think we talked about ISPathWarm. It's a great instrument. You're going to like it. It's really helpful. So suicide assessment is going to happen to you. You're going to do client suicide assessments. And I believe the training you had today will help you make wise decisions. So if they've got a number of these risk factors, if they're saying, this is my plan, I want to go out and kill myself, I've got a gun, I'm ready to hang myself, I tried hanging myself last week, I drank a bottle of vodka, I snorted 2 lines of cocaine, and I hung myself up with the electrical wires off the lamp from my bedroom, but I didn't kill myself. These are high risk factors. They have a previous attempt recently. They're doing drugs. They're doing cocaine, which is really, if they were doing cannabis, oh, yeah, I'm kind of thinking about killing myself, but I'm having such a good buzz right now. I don't want to ruin that buzz. There's less of a probability that they're going to kill themselves. But they're doing cannabis, alcohol. They've had recent attempts. They're highly anxious. They're reckless. They've been withdrawing from people. They have a suicide plan. I'm going to go kill myself with a gun. I'm going to drive my car into my wife's car on I-10. These are all lethal things. So when they have a number of risk factors from ISPathWarm, that your assessment is based on the risk factors they're talking about right now, and the increased probability that they're going to end up killing themselves ultimately. If there's imminent danger, they can be involuntarily hospitalized. They can always be voluntarily hospitalized. I say to clients, based on our meeting today, I really think it would be good for you to admit yourself into the hospital. You're telling me you're thinking about killing yourself, you've got a gun, you attempted suicide last night and last week, and you're angry about all these different things. You've been running your car into people in the crosswalks. I think you're a danger to yourself and others, and I don't think you want to kill yourself, but I think that those thoughts are really in your mind, and it's kind of where your intent is. You just want to escape life. You don't want to put up with your boss anymore because your boss is an old, mean person. crankety and, you don't want to be in a relationship with your partner anymore. You don't want to put up with your kids anymore. It sounds like you're going through hell. So what I would encourage you to do is let's think about involuntary hospitalization. Now, in the Catholic Church, there are things called sins of commission and sins of omission. Sins of omission is you don't tell the full truth. You don't tell everything that's going on. So what I say to people is, if you enter the hospital voluntarily, if you enter the hospital voluntarily, you can always check yourself out if they don't perceive that you're a danger to yourself. And that's 100% true. If the hospital staff does not perceive you're a danger to yourself, you can check yourself out. However, if they do think that you're a danger to yourself, you can check yourself out. But I tell people, you can go voluntarily into the hospital and then you can check out whenever you want to, as long as the staff there doesn't believe you're a danger to self. However, if you don't choose to go in involuntarily and you go into the hospital involuntarily, you'll be there for a minimum of 72 hours as they assess you, which is true. So if you go into the hospital involuntarily, they're going to have you for 3 days, 72 hours. And during that period of time, they're going to continue to assess you, see if you're a danger to self. If you're not at the end of that time, they'll let you go. So I talk to people about voluntarily entering the hospital. And if they want to go home, and if the clinical staff feels that they're not a danger to themselves, they're going to be free to go home. If they're hospitalized because of suicidal ideation. However, if it's an involuntary hospitalization, it's the way it used to be. I haven't checked the laws recently. But if it's an involuntary hospitalization, they're mandated to be there for 72 hours. Listen, I hope this has been helpful to you. I appreciate you. You are going in the most noble profession. I am so proud of each of you. Congratulations. I want you to be a great counselor. I want you to have a great life as a counselor. I want you to have a productive private practice and be wealthy and make tons of money, and then leave financial benefits to UTSA and say, graduated from a great program. I'm going to build a clock at the downtown campus, a chapel with a clock on top and a bell, so we have bells that will ring on the hour, on the half hour, on the quarter hour. Leave that money to UTSA. I'm so excited for you. I hope you're laughing about that. But, if you want to leave money to UTSA, that's fine. I'm being facetious. I'm not. If you want to do that, I want you to do that. With the last name of Junkie, my alma mater talked to me about my leaving money, and then they said, well, we could dedicate a building to you. And I said, what is it going to be, the Junkie building? Let's be realistic. That's never going to work. Meet you at the Junkie building. Yeah, all right. Listen, have a great day. Thank you. You're so appreciated. I'm so proud of each and every one of you. Send me an email if you need anything. Take care. Bye-bye.